Hi, welcome back. In the Part 2 lecture on environmental radiation, we will cover the health effects of radiation exposure and the principles of radiation protection. The extent of the cell damage caused by a radiation exposure depends on the amount of the radiation energy it exerted. The way radiation deposits energy depends on the energy, mass, and charge of the radiation, and the energy-absorbing characteristics of the medium. There are two main categories of radiation effects on cells are of concern. First, the genetic effects, which is concerned with DNA damage and heritable defects. Second, the somatic effects, which occur at higher doses, and related to cell death. Radiation exposures may cause genetic damage and mutagenic effects. Cells may repair this damage, but not 100% effective. The mutation rate is affected by both the total dose received, and the rate at which the dose is delivered. Studies have shown that the relationship between the mutation rate and the dose rate was not linear. Irradiation can also cause chromosome aberrations in the progeny of exposed cells. However, the dose-response relationship between the exposure and the chromosome aberrations was again not linear. There were some inconsistencies in the studies on the adaptive response against the effects of chronic low-level irradiation in humans. The definitive evidence on the inheritable effects of radiation in humans is also absent. Hence, the genetic effects of radiation exposure are generally regarded as stochastic, or random. It is thought to result from random molecular alterations in individual cells that increase in frequency as linear non-threshold functions of the dose. Genetic effects are related to carcinogenicity. The carcinogenic effects of ionizing radiation have been documented extensively by the manifestation of skin cancers and leukemia among pioneer radiation workers in the 20th century, carcinomas of the respiratory tract in underground hard rock miners, and cancers of many organs in the atomic bomb survivors. The table shows the estimated lifetime risk of fatal cancer attributable to low-dose rate whole-body radiation. Somatic effects are those affecting cell survival within the tissues and organs of the body. Radiation damage to genes, chromosomes, and other vital organelles can cause cell death, especially diving cells, which are highly radiosensitive. In general, a dose below 0.5 sievert kills too few cells to cause clinically detectable injury in most organs, other than those of the embryo. A larger dose may kill enough progenitor cells in a tissue, and hence interfere with the normal replacement process of senescent cells, causing tissue atrophy. Usually, this atrophy develops slowly in organs characterized by slow cell turnover, such as liver and vascular endothelium, and faster in organs characterized by rapid cell turnover, such as the bone marrow, epidermis, and intestinal mucosa. Somatic effects are usually manifested in acute large-dose radiation exposure. If the radiation exposure happened at low dose gradually over an extended period of time, the severity of the somatic injury tends to be reduced by the compensatory proliferation of surviving cells. Hence, somatic effects are classified as non-stochastic, or deterministic, because it is mainly dose-dependent. Sensitivity to radiation damage is relatively high throughout perinatal period. The effects of a given dose vary markedly depending on the developmental stage. During the preimplantation period, the embryo is maximally susceptible to killing by irradiation. During critical stages of organogenesis, the fetus is susceptible to induction of malformations and other disturbances of development. Data from the atomic bomb survivors showed that, among those who were irradiated between 8th and 15th weeks post-conception, there was dose-dependent increase in the frequency of mental retardation and decrease in IQ test scores. The available data also showed that irradiation in utero may increase a child's risk of leukemia and other cancers. In summary, ionizing irradiation causes physical, chemical, and molecular changes in a cell, and damages the subcellular components of the cell, such as genes, chromosomes, and other organelles. This cellular damage, if minimal, might be repaired, or undergo random cellular transformation, and give rise to carcinogenic effects. If the damage is severe, it will cause cell death, and give rise to deterministic effects, which are dose-dependent. Hence, when talk about the health effects of ionizing radiation, we will generally classify the effects into deterministic and stochastic effects. Deterministic effects are also called non-stochastic effects, and include acute radiation syndrome, and delayed effects, such as cataract and dermatitis. The stochastic effects are referring to the development of cancers, and other genetic damage. Acute radiation syndrome is a combination of clinical syndromes, occurring in stages, from hours to weeks after exposure, as the injury to various tissues and organs is expressed. The three major systems affected by acute radiation syndrome are gastrointestinal, hematological, and central nervous system. The severity of acute radiation syndrome is dose-dependent. At whole-body irradiation doses below 0.1 Gray, there is no detectable difference in exposed versus non-exposed patients. Detectable increase in chromosome aberrations by cytogenetic dosimetry is found at whole-body doses greater than 0.1 to 0.2 Gray, but still, there are no clinical signs or symptoms. Sperm count decreases to minimum about day 45 at doses more than 0.12 Gray. Further increase in irradiation doses will cause bone marrow depression with lymphopenia at 0.5 Gray. Significant clinical effects start to manifest from exposure to 1 Gray and above. Between 1 to 10 Gray, hematopoietic damage occurs. There is loss of peripheral cellular components, and destruction of stem cells. Death can occur within few hours from bleeding, and overwhelming infection, depending on the severity of radiation exposure. At the higher doses from 10 to 30 Gray, gastrointestinal syndrome with nausea, vomiting, diarrhea, and dehydration occurs. If the exposure is severe, overwhelming infection could occur and lead to death within days. Central nervous system damage occurs when the radiation dose exposure is more than 30 Gray. It will lead to cerebral edema and death within hours of exposure. Acute radiation syndrome or ARS is a complex of acute injury manifestations that occur after a sufficiently large portion of a person's body is exposed to a high dose of ionizing radiation. Such irradiation initially injures all organs to some extent, but the timing and extent of the injury manifestations depend upon the type, rate, and dose of radiation received. The percentage of the body that is injured, the dose homogeneity, and the intrinsic radiosensitivity of the exposed individual also influence manifestations. Different ranges of whole-body doses produce different manifestations of injury. There are three most characteristic manifestations of acute radiation syndrome, which are dose and time profile dependent. These three subsyndromes are the hematological, gastrointestinal, and neurovascular syndromes. These syndromes are, as a rule, produced only with total body or nearly total body irradiation by photon, or mixed photon and neutron radiation. High-dose injuries to smaller percentages of the body produce local injury effects, but may not cause acute radiation syndrome. The three subsyndromes follow a similar clinical pattern that can be divided into three phases, namely, an initial or prodromal phase, followed by a latent phase, and finally the manifest illness phase. If a patient managed to survive the manifest illness phase, he will then go into a recovery phase. The time of onset, duration of each phase, the severity of the clinical phase, and the ultimate outcome, are dependent upon the total exposure dose, and individual radiation sensitivity. Bone marrow contains three cell renewal systems whose time cycles, cellular distribution patterns, and post-irradiation responses are quite different, namely, the erythropoietic, the myelopoietic, and the thrombopoietic systems. A pluripotential stem cell gives rise to these three cell lines in the bone marrow. The stem cell lines of the bone marrow are among the most radiosensitive tissue of the body. This is because of their high mitotic rate, and their high nuclear to cytoplasmic ratio. Patients who have received doses of radiation in the potentially low to mid-lethal range, between 2 to 6 Gray, will have depression of bone marrow function, with cessation of blood cell production leading to pancytopenia. Cytogenetic injury to bone marrow cells and nucleated blood cells can occur at ionizing radiation doses as low as 0.25 Gray, but clinical depression of cell counts is usually not noted until a dose of 0.5 Gray. After exposure to ionizing radiation, platelet counts generally drop in concert with neutrophil counts. Platelet counts drop to 0 or near 0 with doses that exceed 5 Gray. Doses greater than 2 Gray cause an initial paradoxical rise in granulocytes counts, a rise that lasts only hours, or days, and is followed by a precipitous drop. This is caused by prompt demargination of white cells into the circulation. Any full blood count investigation taken during this paradoxical rise may be misinterpreted as evidence of infection. Doses of 2 to 5 gray may cause a second abortive rise, which interrupts the precipitous drop in counts for several days, and possibly as long as a week. This second abortive rise is caused by the products of final differentiation and entry into circulation of marrow polymorphic nucleated precursor cells, which do not need to undergo further mitotic divisions. The extent and duration of this second rise varies, but classically, it lasts for approximately a week, with a rise from about 50% to about 75% of normal. After that, the neutrophil count continues to drop to a nadir of near 0 to 20% of normal, at around 25 to 35 days after exposure. There is usually no depression, or only a very mild depression of red blood cells, unless there is concomitant hemorrhage. With the changes in blood counts, the patient suffers damage to the immune and hemostatic systems. In the week preceding, and during, the neutrophil and platelet count nadir, the function of remaining cells is altered. Not only are few neutrophils and platelets left, but the remaining cells may not function since they are at the end of their lifespan, due to either senescence or radiation damage. If the patient survives neutropenic fever, complications of sepsis, and uncontrollable hemorrhage, recovery following the nadir period can be expected. Thus, the therapeutic goal in the management of such a patient is to lessen the severity of thrombocytopenia and neutropenia, while minimizing and treating infectious damages. Patients injured with ionizing radiation doses within the hematopoietic range will experience prodromal symptoms of nausea and vomiting. They are relatively less severe and easier to control, compared with those for the other syndromes. They last only a few hours, with time of onset from later than an hour, to about 24 hours after exposure. There is usually a lack of central nervous system syndrome signs, very little change in blood pressure, and only mild watery diarrhea. Fatigue, malaise, anorexia, and drowsiness may be observed but are not consistently correlated to dose received. The prodromal phase is followed by the latent phase, that lasts up to a month, and is relatively asymptomatic, except for some tiredness and weakness. The latent phase is followed by the manifest illness phase, characterized by neutropenic fevers, systemic and localized infections, sepsis, and hemorrhage. Generally, exposure to a dose range of 10 to 30 gray is fatal, because that dose range causes reproductive death of the mucosal crypt stem cells. Loss of these cells eliminates the bowel's ability to replenish the short-lived mucosal cells that normally slough off during routine gastrointestinal function. Since the rate of cells turnover is the highest in the small intestine, radiation injury is usually the most severe in that part of the tract. Additionally, there is, to a degree, disruption of neural control of the gut, abnormal release of intestinal neurohormonal peptides, edema of the submucosa, and engorgement and stasis of the submucosal blood vessels. Denuding of sections of bowel, in turn, causes a host of pathophysiological sequelae. They include invasion of luminal bacteria into the circulation, loss of fluid and electrolytes, loss of absorptive capability, significant gastrointestinal hemorrhage and loss of blood, and dysfunctional bowel motility. These pathologies result in severe bloody diarrhea, anemia, ileus, severe electrolyte disturbances, and malnutrition. Prodromal period usually occurs within 30 minutes to 2 hours of exposure. Patients receiving radiation doses of 10 to 30 gray may experience severe prodromal symptoms of anorexia, nausea, vomiting, and occasionally watery diarrhea with abdominal cramps, which increase in intensity for 4 to 8 hours, and may be difficult to control with antiemetic medications. These symptoms are usually accompanied by listlessness, drowsiness, and fatigue. Occasionally, prodromal symptoms include parotid gland pain, metallic taste sensation, mild hypotension, and tachycardia. The prodromal symptoms continue, but diminish over the first 48 hours after exposure. During the latent phase, the patient is asymptomatic for hours to days, but markedly tired and weak. Finally, in the manifest illness phase, the severe diarrhea returns, with vomiting and fever, progressing to bloody diarrhea, shock, and death. The simultaneous invasion of a host of potentially pathological bacteria into the bloodstream quickly overwhelms the victim's ability to fight such infections. Malabsorption leads to malnutrition, paralytic ileus causes vomiting and abdominal distension, fluid and electrolyte shifts result in dehydration, acute renal failure, and cardiovascular collapse. Gastrointestinal bleeding leads to anemia. Sepsis, septic shock, and eventually death ensue. Exposure to ionizing radiation more than 30 Gray will usually end up with neurovascular syndrome. It is believed to be caused by the damaging effects of radiation on endothelial cells, causing vascular leak with edema, and consequently an increase in intracranial pressure. During the prodromal phase, the victim might experience burning sensation within minutes of exposure, followed by nausea and vomiting within first hour, and subsequently, loss of balance, confusion with prostration, hypotension, hyperpyrexia. The latent phase is a brief duration of apparent clinical improvement, usually last only for hours to days. Finally, the victim will succumb to a complex of gross central nervous system dysfunction and total cardiovascular collapse, leading to a relatively prompt and inevitable death. A radiation exposure is considered fatal if you encounter these clinical features. Vomiting within the first hour, especially if accompanied by explosive diarrhea, is associated with fatal doses. Vomiting within the first 2 hours is usually associated with a severe radiation dose. A person who have received a potentially lethal radiation injury will show a significant rise in body temperature within the first few hours post-exposure. The occurrence of a fever and chills within the first day post-exposure is associated with a severe and life-threatening radiation dose. Hyperthermia may occur in patients who receive lower but still serious radiation doses, which are 2 Gray or more. Erythema will develop in a person who received a whole-body dose of more than 10 Gray within the first day post-exposure. Besides, a significant decline in blood pressure has been recorded in victims who received a lethal whole-body radiation dose. Severe hypotension after irradiation is associated with a poor prognosis. Experience indicated that almost all persons who demonstrate obvious signs of damage to the central nervous system within the first hour post-exposure have received a lethal dose. Symptoms include mental confusion, convulsion, and coma. Intractable hypotension will probably accompany these symptoms. Despite vascular support, these patients succumb within 48 hours. The most concerned stochastic effects or random effects of ionizing radiation exposure is cancer development. Most of the solid evidences of carcinogenic effects of ionizing radiation exposure come from the survivors of the atomic bomb disaster in Hiroshima and Nagasaki. So, how do we protect workers from radiation exposure? Radiation protection measures are selected to prevent either internal or external contamination, or both, depending on the conditions and radionuclides involved. Internal contamination is referring to the entry of radionuclide substances into a human body, whereas, external contamination means the contamination of the surface of a human body by radiation. Radioactive materials can enter the body through inhalation, ingestion, or absorption through skin, or a wound. Each of these pathways has associated engineering controls and protective measures to avoid exposures. Several principles guide the efforts to minimize risk of radiation injury, consistent with general preventive approaches in environmental health. First, no activity involving ionizing radiation should be considered justifiable unless it produces sufficient benefit to those who are exposed, or to society at large, to offset any harm it may cause. Second, in any such activity, the dose or likelihood of exposure should be kept as low as reasonably achievable, taking all relevant economic and social factors into account. Third, the radiation exposure should be subjected to dose limits, low enough to prevent non-stochastic effects altogether, and also low enough to prevent the risk of any stochastic effects from exceeding socially acceptable levels. To control against the risk of radiation exposure, there are 3 factors that need to be considered. First, the time of exposure. The shorter the usage or exposure, the lower the risk. Second, distance. The further away the source of radiation from the body, the lower the risk of exposure. Third, the shielding effect. Shielding equipment or structure protects the body from direct exposure to radiation. Radiation control techniques can also be applied according to the hierarchy of occupational hazards control, namely, elimination, substitution, engineering control, administrative control, and personal protective equipment. Have you noticed that the guiding principles for radiation protection that we have mentioned just now are actually consistent with the first two hierarchy of occupational hazards control? These are the most important principles in the radiation exposure control. The use of radiation exposure techniques, namely, minimizing exposure time, maximizing source distance, and applying shielding, are consistent with engineering and administrative controls. Personal protective equipment in radiation protection should be used as the last resort when all the above control measures are in place, or during emergency situations. According to the International Atomic Energy Agency, all workplace dealing with ionizing radiation must have the following strategies in place. First, the workplace must have the proper design and engineering controls against radiation exposures. The workplace must have licenses and operating parameters consistent with its design, complying to national legislation. A robust radiation protection program must be in place. The workplace must have workers who are adequately trained and supervised. The workplace must conduct operations with sufficient planning, procedures, and oversight to integrate safety management system into all business processes. The company must engage independent oversight to explore root cause analyses, lessons learned, corrective actions, and continuous improvement. And finally, the workplace must have a well-developed and maintained emergency preparedness plan, in order to be able to respond promptly and effectively, in the event of a malfunction, spill, or other type of radiation accident. In Malaysia, the use of radiation energy is governed by Atomic Energy Licensing Act, 1984. Under this act, the Atomic Energy Licensing Board was established in 1985, and acts as an enforcement authority for the implementation of the act. In 1990, the board was then placed under the Ministry of Science, Technology, and Innovation. Three of the regulations under this act, namely, Radiation Protection Licensing Regulations 1986, Radiation Protection Basic Safety Standards Regulations 1988, and Radiation Protection Transportation Regulations 1989 were established to control the radiation exposure in this country. There are other important regulations under this act, all serve to safeguard the population from hazardous radiation exposure. In general, a proper radiation protection program should contain at least the following items. A risk assessment process must be in place to assess the risk of radiation exposure among all workers in the workplace. The workplace should engage a qualified radiation protection officer to manage all safety issues related to radiation exposure. The facility must contain appropriate and adequate safety features. There should be rules, regulations, or guidelines in place related to the radiation usage. There should be a proper health surveillance on radiation effects. An emergency preparedness plan must be in place, and drill to be carried out regularly. And, finally, trainings must be provided to all personnel working with radiation source. Thank you for your attention.